Hi everyone, my name is Ann Saffron-Dalen and I'm a person living with diabetes, and I'm happy to say that in January of this year I became a transplant recipient. Thank you for watching this edition of the National Kidney Foundation Diabetes Sister and Women Heart Facebook Live series. Today is the third edition of a three-part series on the subject of diabetes, cardiovascular disease, and kidney disease, and today the focus is on how these important health issues affect diverse communities. Once again, we're lucky to be joined by three terrific panelists. Dr. Kurt Campbell, a nephrologist at Mount Sinai Hospital, Dr. Ina Nelipovich, a cardiologist and director of the Women Heart Program at Maimonides Hospital, and last but not least, Dr. Dina Adamulam, who is an endocrinologist also from Mount Sinai.
Thank you for having us.
Thank you so much for joining us today.
Thank you.
So let's get into the questions. That's what everybody's waiting for. Let's discuss the risk of diabetes, heart disease, and kidney disease, and how they differ from people from diverse communities, including Hispanic, African American, Native American, and South Asian, as well as for men and women.
Sure, so I can answer that question. So basically, when we talk about the risks of diabetes, we're really talking about the micro and microvascular complications of this disease. These are just really fancy terms to sort of explain how diabetes affects both small blood vessels, leading to what we call microvascular complications, and larger blood vessels for what we call macrovascular complications. So when we talk about the smaller blood vessels and these microvascular complications, we're specifically talking about how diabetes can lead to eye damage, which can lead to a problem called retinopathy, how it can affect the kidneys, leading to a problem called nephropathy, and how it can affect the nerves, leading to a problem called neuropathy. In terms of the macrovascular complications, we specifically talk about how it can affect the heart, leading to complications such as heart attacks and heart disease, as well as stroke, in addition to what we call peripheral vascular disease, which is really just related to narrowing of the blood vessels, especially to the legs, which leads to decrease in blood flow, which can lead to other complications.
Thank you. Would anybody else like to join in?
So as a cardiologist, I don't see just diabetes. I see multiple complications of diabetes and kidney disease. I don't think you could separate one disease from the other. They are so interconnected, one leading up to the other. And a lot of the times what we'd like to do is primary care, primary prevention, meaning prevent disease from affecting your whole body. But a lot of the times we end up picking up at the secondary prevention where the heart attack already happened. There is already kidney damage. There are peripheral complications, somebody losing a toe because of the peripheral vascular disease or neuropathy, a person coming in with strokes, with poor kidney function and heart failure. And my job as a cardiologist is not in primary prevention anymore, it's preventing other heart attacks from happening, preventing the person from losing their limb. It's very difficult to separate one disease from the other without understanding how the impact of diabetes and kidney disease affect the heart, because they're not separate systems, they're intertwined. And a person's understanding of one or the other, you can't separate saying, well, I just have this disease and not that one. One ends up leading up to the other.
Thank you, yes.
No, I completely agree, and I think you will often find physicians echoing the same message, right? A disorder like diabetes affects multiple organ systems, right? And the blood vessels primarily, as Dr. Adamulam mentioned, are affected across a variety of different organs, right? So if you think about it, same blood vessels that can be impacted, leading to eye disease, heart disease, also lead to kidney disease. So when we encourage from the kidney standpoint, patients are often a bit surprised to hear a kidney doctor or a cardiologist talking to them about their blood sugar, right? But you know, it's absolutely all interconnected, and the more we can sort of hone in and highlight that message, I think the better outcomes we'll see from patients.
Yes, and I've learned what that means from what all you have said is that you need to have a team. If somebody has heart disease, they should look into finding out, do I have diabetes? Because quite often that could be behind it. I learned that. And then a nephrologist is going to connect to everything else. So if somebody focuses in on one thing, they may be losing a lot of time that they don't have to lose with having the disease advance.
Right.
You know, I was thinking it would be nice if I had a nephrologist and a endocrinologist sitting right by me when I see my patients.
At all times,
because
right.
it wouldn't be like, oh, did you know you have diabetes? You know, and the person saying, what?
Right.
It would be nice if you were this close by.
Sure, I'm happy to join you. I think one of the things that I do as an endocrinologist, seeing a lot of diabetics in my practice, is really, as soon as I see an early sign for any evidence of kidney problems, to send them to a nephrologist early on, because you guys can actually provide us a ton of expertise, more than what I'm able to do in my office. And the same thing goes with heart disease. So I think it's, if there's a patient watching today, who's concerned about their heart or their kidney function, or their doctor said, hey, maybe there was something abnormal with my labs, it's really important to maybe talk to them about being referred to some of these specialists, because we are a team and we're all here to really help the bottom line, which is the patient, and trying to prevent these complications from getting worse.
Absolutely. And diabetes is the #1 reason people end up on dialysis, right? So it's the #1 cause of progressive kidney disease. And the complications, right, from diabetes affecting the heart and the kidneys, they tend to be more prevalent, right, in patients from underrepresented groups,
Yes,
right?
yes.
And this, we know that there are a variety of reasons for this, and there are also some gender differences in susceptibility, right? From a kidney disease perspective, women are more likely to have chronic kidney disease, right, from diabetic complications. I know we've discussed this.
And wouldn't it be nice if a person got diagnosed with it early, so they can get their A1C under control? If we picked up somebody who has early stage 3 kidney disease, and not when a person is facing implications of dialysis, it wouldn't be nice as a cardiologist to see a person saying, oh, you have mild but well-controlled diabetes, your blood pressure is almost near goal. You should see your endocrinologist just one more time, and then we could coordinate, get your cholesterol under control, and you'll be well on your way. And we'll just test for your risk factors and keep watching it. But a lot of times we don't have this option. We're always playing catch-up to, well, why is your A1C level still 9? Why is your kidney function keep worsening? What are you not doing? And I feel like I don't want to put the patient living with kidney disease or diabetes under attack, but a lot of time in the office with limited time that we have, it ends up being an attack on the patient saying, why are you not doing this? Even though our role has to be educational and prevention.
Yes. And we have to, as a patient, be proactive. When we leave a doctor's office, there's so much going on. It's good to bring a person with us quite often, especially when you're given a diagnosis, because once you're given a diagnosis, quite often you don't hear anything else. So when you leave the office, you don't know what to do. But if you bring somebody with you that can be your ears, that makes a huge difference. And then you can work as a team, because you need, and even if they're not officially a caregiver, but they're there helping you, and that helps you work with your doctors, and it becomes a team. So that reinforces things that people need, that anyone needs to do.
Absolutely.
So, why don't we move on to another question? And is there a difference between the impact of diabetes and high blood pressure on kidney and heart health between men and women?
So the interesting thing is diabetes is actually more common in men than women. I think a lot of people don't realize that, but that's actually the case when we look at the statistics. But what's even more interesting than that is, even though men tend to have diabetes more than women, the risk for all the complications that I sort of mentioned before, they actually affect women more than they affect men. And I know that Dr. Campbell sort of mentioned a little bit about nephropathy, but which is kidney disease, but we actually see that across the board in terms of all complications related to diabetes. And a lot of people try to understand why. And as a hormone doctor, we tend to believe that a lot of it may be the change in hormones, especially in women, as we go through something called menopause, where we have a decrease in the level of estrogen. There tends to be a change in terms of the cholesterol balance in our body as well. Women tend to have something called HDL, which is what we deem as the better cholesterol, which is at a higher level. And as they go into menopause and past that, there's a little bit of shift to less HDL and more triglycerides, which can sometimes make their diabetes worse as well. And so that's one hypothesis as to why we feel that way. There's also other different medical conditions after menopause with women that may predispose them more so to these complications, especially depression. It's something that we don't talk about.
And it's an under-recognized risk factor for heart disease as
That's
well.
right. And we never talk about depression. We never really talk so much about, how diabetes affects someone's mental state, right? And when you have a complication of diabetes, your life changes drastically. Yes. It changes the life of you, it changes the life of your family and your loved ones.
Right.
And it has huge implications in terms of, developing these other issues like anxiety and depression. And we don't talk about that. And I think it's really important that we do. So just mentioning to you all that depression is something that we do need to be screening our patients for. And if you have symptoms of depression, you need to talk to your doctor about that, because depression leads to poor diabetes control. If you're already feeling sad about yourself, you don't take care of yourself properly. And that can potentially lead to complications too. And women tend to be more depressed than men later on in life as well. So
we know depression is a risk factor. It's one of the less talked about risk factors
right.
for heart disease as well. Just like high levels of stress for women also affect their health. In terms of the cardiovascular risk factors, women present differently with heart disease. A lot of the times women have more of the risk factors at the time they present with heart disease. And I think what we mentioned before about pre and postmenopausal, there's actually two separate things that we worry about with premenopausal women, with postmenopausal women and heart disease. In the premenopausal women, and these are emerging risk factors for heart disease, it's the gestational diabetes, meaning if you develop diabetes during your pregnancy, that could be a warning sign that you are at risk of diabetes later in life. Preeclampsia, a condition where you have elevated blood pressures, edema, and additional effects on the liver, sometimes evolving to eclampsia, which is associated with seizures, is also an under-recognized risk factor for hypertension later in life, which can lead, if not recognized, to kidney disease, and or even hypertension during pregnancy. All of those things, premenopausal things, you don't think about, they're risk factors for later in life. And then postmenopausal women, well, it's a whole different thing. This is what I like to do for a living. I try to educate women to say, well, guess what? Your symptoms will be different for heart attack. A lot of the times, the symptoms are subtle. The symptoms are not what's written in the textbook. It's not crushing chest pain. It's discomfort. It could be attributed to stomach ache or indigestion. It could be neck pain, muscle aches, things that are not very specific for heart attacks, but you have to be vigilant.
that's right.
And a lot of the times, women do not know they have risk factors. They're not screened properly for diabetes, for high blood pressure, for the emerging risk factors in time to catch a heart attack. And the other side of it is educating medical community to recognize the subtle risk factors for heart problems, as well as being very aggressive with blood pressure control. With the blood pressure control, which can lead, hypertension does lead to kidney disease, it's very important to get the blood pressure under good control as well.
Right.
So I think in terms of that, women are dealt with a bad card where we are catching up to risk factors, and not even prevention, but just risk factor modification at this point.
Yeah, and I think just to echo that, with the higher prevalence of kidney disease, right, especially the earlier stages of kidney disease in women, that alone increases the risk for heart disease, right? So having kidney disease is one of the surrogate risks, right, that you see closely associated with the risk of heart disease, which as we discussed, can present atypically in women. Right. So it requires a lot of vigilance, understanding that certain patients have a more significant risk of developing these complications, and really looking for them more carefully and treating appropriately.
And because they're silent quite often,
Sure.
that's why we have to be vigilant about going to our doctors.
Absolutely.
And having those tests. That's how things were caught for me.
Right.
I felt great, but my body may not have felt as great.
That's right.
And it showed up on my tests.
Yeah.
So that made a huge difference.
Yeah.
And speaking of that, let's move on to one of the most important things, and that's a lifestyle change. And I'd like to know what you recommend to improve heart and kidney health.
Yeah, well, there are certainly a lot of things that can be done. And in fact, when we think about it from a bigger perspective, right, The consultations in the office, right? Visiting the doctor's office, getting prescribed medications, that's really a small piece of what can be modified to improve general health, right? So not specific to diabetes or kidney or heart, but overall, patients are empowered, right, to make a lot of changes with respect to diet, physical activity, rest, mental health. We've heard all these things, right? And these are all arguably more important than what medication you're prescribed, right? So it starts off with really making changes in the home. And you know, there is a genetic predisposition to some disorders. There are some traits that are inherited. So there is a certain built-in risk profile, but a lot of the outcomes are really modifiable, right? And we're going to talk a little bit about the diet, right? In particular, right? And you know, having the appropriate balance in your diet can lead to better control for your diabetes, for right heart disease, kidney disease, and we've known for kidney disease, for example, appropriate physical activity, appropriate exercise, you know, aerobic exercise, and you know, not having a sedentary lifestyle can improve outcomes for kidney disease. And depending on what stage kidney disease patients are in, there should be a certain amount of protein intake, right? You know, in the advanced stages, we don't recommend a high protein intake, but you know, early on, you do need an appropriate balance. The Mediterranean diet tilting towards, don't want to step on the cardiology.
But what would you say? Cut out the salt or the protein?
Well, there you go, right?
Right.
So it
Which
depends.
one do you choose? Or the carbs?
Right.
So that's why I think it's important to, you know, we try to practice personalized medicine, right? So I think that's really important to remember that this is not cookie cutter medicine, meaning that one size fits all in terms of the lifestyle changes that we recommend. So Dr. Campbell touched on some of the risk factors that we see for why these certain populations are at risk. And I think it's really important for us to engage with our patients and really understand where they're coming from and who they are. Because as much as we want to talk about lifestyle, we need to talk about lifestyle in relation to them. So we need to talk about lifestyle in relation to what they're eating, what are their cultural norms, and what's actually going to work, as well as lifestyle in terms of exercise. I can't even tell you, you know, how many patients I tell them, okay, well, you can walk a little bit more every day. Get in those 10,000 steps every day. And then they tell me, do you know the community that I live in?
And
It's
I was
not
going to bring
safe.
it up. Do you know some neighborhoods you cannot walk outside
I know, that's
well
right.
without worrying
Yeah.
about certain issues
Exactly.
happening? And not everybody has access to gym or
That's right.
Swimming pools or whatever, right?
Right.
Yeah,
I mean,
so-
it wouldn't it be
Exactly.
great?
Yeah.
And sometimes I find it's empowering patients when you just suggest one lifestyle modification, something achievable to start with that. I think you mentioned it before in one of the conversations we had off screen, that you know, taking your medications is sort of a lifestyle change as well. You know, being able to take the medications properly.
Yeah, so I think it all goes back to just understanding what are the barriers. I think the biggest thing I hear from patients, and I hope our audience helps us with acknowledge this as well, is that there's really poor communication between the patient and the doctor. And what the doctor wants is completely different from what the patient wants. And we just happen to give them a laundry list of things to do without thinking, who is this patient? Are they going to accomplish this? I can give you an example from yesterday. So I saw a patient from the Dominican Republic, and we sort of spoke about his diet, and I asked him, do you eat a lot of carbs? And he said, no, I only eat 2 cups of rice a week. And he said, I barely eat any carbs. And I said, what about vegetables? And he said, well, I eat potatoes, I eat yuca, I eat plantains. And I said, yeah, and I said, do you realize that those are carbs? And then I said, well, what about green vegetables? And I started asking about lettuce and broccoli and spinach and kale, and I couldn't imagine that there were some foods that I was recommending that he's never even heard of, like things like cauliflower or kale, or things that he's not familiar with. So just to even take the next step and just understand what is it that they're actually consuming and what are they used to and what can we actually introduce them to that they're going to be able to get in their local market,
right, and it
makes a huge difference.
I agree with you. A lot of the times from my work when I did my training in the Bronx, the access to fresh food is different
That's
there.
right.
Access to
Yes.
fresh vegetables is different there depending on where you live. So just throwing it out there saying, oh, eat more vegetables,
Yes.
it's a very non-specific recommendation. It doesn't work this way.
Yes.
Being able to understand what are the cultural differences, even between the physician making the recommendation and the patient and their family. It's a big difference. I mean, we had something along the lines of that. One of our diabetes classes during the residency, and the patient whose A1C was 9 or 10 raised his hand and said, "What about fried pork?" And everyone turned to him and said, "But you already had a couple of heart attacks. What happened?" And the person said, "Well, this is what in my culture I eat."
Right.
It may not necessarily be that, but I mean, different communities have different dietary changes. And I think it's always a good idea to bring in a dietitian into the conversation. I recommend it for my patients at least once.
Yes.
Right.
And on that note, how about some tips that help control the intake of things like salt, sugar, cholesterol, anything that will affect the patient's health down the road?
It's interesting, oftentimes from a kidney standpoint, we do recommend low salt intake, right? We know that blood pressure medications work better if the salt intake is less than 2 grams per day, right? Patients will often say, "Oh, I don't add salt, I don't use salt." But then when we inquire, they're like, "Well, I actually don't cook either, so all my food is takeout." So they're not adding salt to the food that's already salt laden. So unless you're preparing fresh meals or preparing your own meals, you can't fully control how many of these additives are there, right? So we always encourage fresh preparation of meals, limiting the processed foods. That's normally a healthier way to go.
One of the first things I do with my patients is try to educate them on reading nutrition labels.
I was going to say the same
and
thing.
they say, "Oh, I don't know how to do that." And I said, all you have to do is look at ingredients. And if there are things in there that you can't pronounce or you don't understand what they are, that means that this is not natural.
Exactly.
And you probably should consider looking at another item or something else. There's a ton of added sugar out there. High fructose corn syrup is just another fancy name for sugar. But people don't know these things, and they're bringing that into their homes. They're feeding that to their children. They're predisposing them to developing problems too. And I think that's something that we always focus on, is reading labels and understanding where are these hidden sugars, where are these hidden salts as well is really important. I also really focus on making your plate more green. So I always try to focus on making sure that we can get in those green vegetables, which have a ton of vitamins, nutrition, fiber. Those will help with diabetes, and they can help with weight loss overall as well. So I always recommend that. So half of your plate should be green vegetables, a little area for carbs, and a little bit of an area left for some protein.
And something else that's important, and we have water in our cups, so drink lots of water.
Yes.
Actually, it's good for the kidneys.
Yeah,
There we go.
absolutely. Yeah, and it's an excellent way to sort of get in less soda, less
soda.
juice.
Right.
Just drink water. Water is free, and water is very healthy.
But according to cardiologists, less than 1.5 liters a day.
Okay.
People tend to say you need to drink half your weight in ounces of, and it's like,
That's
oh
so
my.
confusing
It is
to sit down with a
confusing.
calculator and try to
Exactly.
figure that out.
So
But what's the general amount you think is good, but it's not going to overwhelm your system? Let's say if you already have existing kidney disease, something in the moderate variety, what would you say?
No, it sort of depends on what the underlying physiology is. I mean, patients have kidney stones. We tell them drink like 3 liters
Yeah,
or so or
that's
more, right, to really flush things out. But on balance, 2 liters or so, 1.5 liters, I mean, that's pretty reasonable.
Because from cardiologist's perspective, a lot of the patients that I take care of also have congestive heart failure.
Right.
This is a condition where they develop fluid retention,
Right.
and it ends up being in the legs and in the lungs, and people have difficulty breathing. And we end up sort of playing a tug of war with the nephrologist, because in order to get rid of the extra water, we give medications that affect kidney function. And it's a little bit difficult for us. For us, the recommendation for fluid intake may be less.
Right.
And you have to also talk to your doctor, depending on your risk factors. It's what you
Yeah,
mentioned
and
before,
it depends
individualized.
on how significant your diabetes is too. One of the main symptoms of diabetes is feeling excessively thirsty, right? And so the patients are going to want to drink more water to quench their thirst. So it's a good balance, but the important thing is to get water into your day.
And
That's the bottom
let's
line.
move on, because this fits into it also. How do cultural diets impact risk and management of heart disease, kidney disease, and diabetes? Because every different cultural background has their focus on what their main, whether it's protein or carbohydrate, and they're a very important part of what they do. But I know that these things have to be changed, and how do you go about doing that?
Yeah. So it sort of touches on what I had mentioned before about the personalized
Yes.
approach to this, right? And so I think, if the physician themselves don't feel necessarily comfortable with understanding diet and nutrition, then definitely getting a nutritionist involved as well is really important. I think it's really hard, right, when it comes to certain cultures, telling them to cut back on carbohydrates. So I gave you an example of a patient who's from Dominican Republic, where their vegetable is basically a starchy vegetable, which is high in carbs. So you have to sort of figure out a good balance. Well, how do I not tell them to stop that completely, but tell them to cut back and maybe add in other vegetables that might also be appropriate for them? I think with South Asians, as we talk about cultural diets, really important to look at the South Asian diet, which rice is a staple. Rice is a staple part of their everyday life. There's rice in breakfast, lunch, and dinner. And so to tell a South Asian person, like people in my family, to cut back on rice completely, that's not going to happen.
But what would work? What do you think would work?
So, you cut back in moderation. You do moderation, right? And so maybe you're not having, something with rice every single meal. Maybe you're cutting back to maybe half the meals of your day. Or maybe you're choosing other alternatives to rice that might be a better option. So instead of white rice, we might use quinoa, or we might use, whole grain rice. Instead of eating bread, maybe you're going to go breadless, or you're going to try wheat flour-based products. So, it's just a matter of working with them to see what's reasonable, because I find that if I tell people to cut something completely out of their diet and that's their cultural norm, it doesn't last. And I think, that's the mistake that some of us make, is just to assume that, okay, should just stop eating this completely and it's going to get better, when that's a huge part of their life.
A part of it I think also works is a person doesn't realize what they're eating because it's the norm. Sometimes it's a good idea to keep a food diary. Take pictures of the food you eat. It will help you figure out, well, this is what I eat during the day, and this is what I can cut out. What do you think of the plate approach? Like if you use a segmental plate and the third is vegetable, does it really work in real life? I'm not sure.
I think it does work for some people. I think, when it comes to diabetes care, there's a lot of education that we have to have one-on-one with the patient, and it doesn't happen at the first visit. It happens at multiple visits as you develop a relationship and you understand the barriers. I think from my patients, the best physicians or best treatment that they've had has always been a team approach, right? So everyone working together to try to understand what their needs are and to focus on them in a different way. I think that's really what works.
No, I totally agree, and one of the reasons as well that we started developing a nutritionist focus to our practice, where we actually have a dietitian embedded within our kidney clinic, and it's been very, very helpful. So she can see patients in a walk-in capacity or scheduled appointments, but just like you said, really in a culturally sensitive manner, going through the complete daily diet for each individual patient, because it will vary, and understanding what they eat, what they enjoy eating, and making the appropriate recommendations is quite important.
And in some of these communities, one of the biggest risk factors is non-biologic, right? So it's limited access to food. It's limited health food access. I mean, some of these places, we call them food deserts, where we see a huge number of people with diabetes and heart disease and all these complications that we're talking about today. And in these food deserts, people go miles to find the next supermarket. I mean, you can imagine, even within New York City itself, how far people have to travel from places like the Bronx to get really healthy food. And I never understood that until I actually put myself in their communities to really understand what's going on. A lot of people go to these bodegas, which are these local corner stores, and that's where they get all their fruits and vegetables. And unfortunately, there's just not enough in those areas where there's fruits and vegetables, so often these patients are going to processed food. So if you tell them, eat fruits and vegetables, and they don't have access, it's just impossible.
But it's also a socioeconomic issue, because fresh food, the one that you need to cook, fresh meat, all of that is more expensive. It's more expensive to buy a pound of organic apples, let's say, for example, than it is to buy something at the fast food place that could feed your child. It's quicker and it's less expensive. But what I end up doing is eating processed foods the one where you cannot control the
That's right.
cholesterol, the sugars, the salt, because it's easily accessible. And the things that really need to happen is education of a patient, what they're doing, and what they can do to change. We understand we may not be able to change poverty in this country. We may not be able to change the access to fresh food per se, but educating the patient, if they could do one lifestyle change, the one that makes the biggest impact, I think that makes the difference. Because once you have a patient and you give them control and it works, then they can take the rest of the lifestyle changes. Same thing with exercise.
And it's
Same thing
also
with other
important
things.
not just to think of it from how it's affecting the patient, because often these patients are parents. They have families and kids. And what they're feeding themselves, they're feeding their families as well. So they're just increasing the likelihood of their kids to have the exact same problem. And then the process just continues. And that's the biggest problem here with why these disparities are existing, in these communities.
At Diabetes Sisters, which I'm part of, and I lead a group, and I'm very active with them. One of the groups had, which is predominantly South Asian, had a speaker come in. The room was filled, and it was men and women for this program. And there was a woman who was a dietitian, but she was a cookbook author. And she spoke their language and went through different foods that affected them and talked to them about the change that were necessary and how they can do it gradually. And people responded with more questions than I ever could have imagined. It was wonderful. I learned a lot. And so all these things make a huge difference.
Absolutely.
Huge difference. So why don't we move on to one of the other questions on the board here. We went to lifestyle changes. Let's talk about how the diverse communities can play improving the understanding and impact of these conditions. Because, again, with things being silent, they don't realize that their lives are being impacted. If you feel fine, you don't respond. You think, I'm okay, but you don't know what's going on inside your body. How do you get patients to understand that even though they're okay on the outside, things could be taking a turn for the worse on the inside?
Sure. So I think a lot of that goes into education. And I always hope that there's these leaders, my patients can be leaders in their community to sort of spread the education and the awareness of diabetes in some way, whether or not that's asking their family members if they're getting screened for diabetes, whether or not that's talking about the foods that are maybe better for them to be using every day. Just building this awareness amongst their own community members, I think is really important, because honestly, as much as the doctor tells the patient, to do X, Y, and Z, the community is really the key player in really helping to decrease the prevalence of these diseases. They know more about how to control lifestyle in their community than we do, because they're living in it 24/7. And so I always try to get my patients to advocate for themselves and to raise awareness in the communities. I also, make sure that these specific patients are understanding of the different resources that are available to them as well. We talk about poor healthy food access, but there's a lot of food pantries and food markets that actually cater to some of these underserved populations, and they'll provide them with vouchers for meals as well as vouchers for less expensive produce.
I just wanted to quickly mention, communities, we're talking about community centers as well as churches, places where people actually get together. These are the places where we can make the most impact. Make the most impact in terms of, this is a place of trust. This is a place where we can introduce the screenings. This is the place where people go for information. Who is a good doctor to see for diabetes? Who is a good doctor to see for kidney function? So if we are able to work, the physicians are able to work with the community leaders to offer the screenings, if we're able to work with the community and bring in screenings to the community center, to the church, take it out of the hospital, we may be able to prevent a lot more of these things happening. And also patients acting as advocates, patients acting as educators for the disease. Women Heart does an amazing job of creating opportunities for women survivors of heart disease to come out, and they do additional training, and they educate other women about their heart conditions, how they present it, what was done. And I think using advocates, patient patients advocates.
Right.
It's an amazing opportunity for somebody who is on the same level as the other people coming in to talk about the problems.
Yeah. And actually just building that community movement to improve access to healthy foods and fresh foods, crucially important. You know, we talked about how much more expensive healthy foods and fresh foods are. It's really no surprise that poverty actually is a risk for kidney disease. And it's likely related to limited access to healthy foods, right? And that can impact, again, all the risk factors that we mentioned here, right?
Absolutely.
So they're all interconnected, but it starts with the lifestyle, which is largely built on access that's available in the community, right? So it's all intertwined.
Thank you. I'd love to keep going here, but why don't we take a few questions and from the audience, and they're on Facebook, and let's see what they're asking. I'll remind you that if you have any questions on this subject, please post them in the comments section. We'll do our best to answer as many as we can. And please know that if we run out of time, all your questions will be answered on the NFK's Facebook page in the coming days. Here's the first question. Ready? Okay. What are some of the tips to manage medication schedules, especially when multiple medications are involved? And that's something I'm doing, so I have experience with it.
Please tell us.
You saw me with my little snack bag,
right.
but let's hear from the professionals on what they suggest.
Okay. So, you know, again, I'm all about personalized medicine to try to ask my patients, like first having an open line of communication. You know, what exactly are the reasons why you're missing meds? Is it because you forget? Is it because you're traveling and you don't have your insulin with you? Like, what exactly is the reason? And once I know exactly maybe why that might be the issue, then I can, you know, give them a plan of action. But typically, I've recommended patients setting alarms on their phone as a way to remind them to take their meds. Pill boxes, I think, are an excellent resource. You know, having your medications laid out for you for the week so that you know Monday, Tuesday, Wednesday, Thursday, Friday, etc., that you've actually taken your medications, you know, through the day. And like I said, a team approach, not just with your doctor, but with your family and your loved ones is really important. So, you know, work with your family to try to make sure that they're aware of the fact that you need to take your medications, and hopefully they can remind you as well, and you're all in it together in some way.
I also find family involvement is so important. My patients do much better if their family comes to the appointment. My patients do so much better if the family checks in that the medications are properly laid out in the pill boxes. So if they're missing, or some of the pills stay in the pill boxes, it helps. The adherence to medications makes a big difference, big impact. Also, some of the patients create charts and come in with lists of your currently taking medications to your doctor helps, because then we don't have to figure out what are you really taking. And also making sure, talking to the pharmacist, that patient's actually able to fill the prescription you're writing. That's a big deal.
And for like those with diabetes, or you know, specifically dealing with issues with your, let's say your oral diabetes medications, important to talk to your doctor about, you know, these drugs that can be used in combination. So now we have a lot of these combination drug therapies. So Janimet, for example, is a combination of Januvia and metformin. So you don't necessarily have to take, you know, 4 pills a day. You can just start by taking 2 tablets. So ask if there's a way to combine your medications. That might be helpful as well.
Yeah, absolutely. Reducing the pill burden is a great way to go, and some of the lifestyle changes that we discussed. I mean, there have been patients who have come off blood pressure medications because they've lost so much weight and exercised so effectively. That's an excellent outcome, right? So ideally, you want to make changes that can reduce the number of medications you actually do have to take, but strategies to remember are very helpful.
Yeah, and I think that's a good point. I think a lot of people think that, you know, I'm taking these medications, I'm doing these lifestyle changes, and I'm going to basically be continuing with meds anyway. And the truth is, you can come off of medications no matter at what stage you are of your diabetes. There's a potential for you to get better with lifestyle changes and for you to be able to come down on your medication to decrease that pill burden.
I think we have time for one more question. And this one is, what are hospitals doing or should be doing to increase awareness to promote healthy lifestyle and preventing care? And actually, you reviewed quite a bit of that, talking about reaching out to the community.
About it. Sure, and creating screening opportunities. If we bring screening into the community, it will make a big difference. It's coming to the places where people trust. It could be a community center, it could be a community organization or a church or even a barber shop, if you think of a specific study. But bringing in screening into these communities, screening for the cholesterol, screening for diabetes, screening for high blood pressure, figuring out what is the need in the community, working with the community leaders. That's what the hospitals can work on. Creating screening opportunities and taking them out of the hospital so the patient doesn't come in with acute issue. I think that that's a big deal.
Yeah, and I think a lot of the hospitals are also pushing for these classes as well. I know that within our own diabetes program, the government is actually funding to have these diabetes education classes. So you come in with a group and you learn about diabetes and you have your questions answered, which I think has been really helpful for a lot of patients. There's also a lot of different food classes, nutrition classes, as well as exercise programs that some hospitals have been able to provide the community with.
Well, it looks like we're almost out of time.
Oh, okay.
Yes, and so I hope this was helpful for everyone. I remind you that in case we didn't get around to answering your question here, please check the National Kidney Foundation's Facebook page where we will be posting the answers. You can always contact the NFK's helpline. That's toll-free at 855-NKF-CARES. And at this time, I'd like to thank our sponsors in being so supportive in helping to make this program possible. And I'd especially like to thank our guests, Dr. Campbell, Dr. Nelipovich, and Dr. Adamalan.
Thank you
Thanks
so
for having
much.
us.
Thank you.
You're
Thank
very
you for the
welcome.
opportunity.
And now, on behalf of the Kidney Foundation, Women, Heart, and Diabetes Sisters, I'd like to wish you all good health.